So today's session, forget who this came from, I have to say, but it was one of my members who prodded me in the ribs and said, I really don't understand why we've got all these terms about data and how data gets used for research. You've got secure data and federated data and all these other things. I don't understand it. Could you put a session on to try and figure out what all these things mean? So this is my attempt to put a session on to figure out what all these things mean. And I'm going to start sharing my screen now. Super. Um, so this was the challenge I was given, and I cut and pasted from the email I got from somebody, which was exactly this. SDE, TRE, FDP, safe havens, honest brokers. These are terms that they had heard around data usage. The little subplot there, how many names do we need, is me, just being facetious. But we want to go through each one of these, say what they are, say what the differences are, and say pick up any significant things you need to think about when you come across these terms. You will come across other terms to do with data storage and research as well, in which case flag them up where we've got a glossary of terms which Jackie did some work on ages ago, which we can send out to people. I think Elizabeth's going to be sending a version out of that fairly soon. So first of all, what do we mean? So I try not to use acronyms. You know, we don't use acronyms, but I pasted them in there because that was what arrived in the email that came to me. So the first three, SDE, Secure Data Environment. I suspect most of you on here will have heard of that term. The second one, TRE, stands for Trusted Research Environments. The third one stands for Federated Data Platform, which is a specific thing which NHS England have procured. And then the other two bits, safe havens and honest brokers, they're almost self-explanatory, but we'll go into those in a minute about what they are. So SDE, Secure Data Environment, TRE, Trusted Research Environment, FDP, Federated Data Platform. And I'll explain what those things are and why they're different. Something to think about when you're going through these things. A few people have said, well, why have we got trusted research environments? Why have we got safe space and secure spaces? And all these words keep popping up. The first question people say is, well, was it not secure before that? Is there something new? Is it a new concept? And the answer is, well, it isn't new at all. And if you look at, I don't know if any of you have ever tried this Google Ngram viewer. I suspect the more intellectual ones will have seen this, as one of you pointed that out to me. It's online. Google Ngram, it's called. If you Google it, you'll find it. And it basically is digitized all the books, publications from the 1800s, and you can go and search for words. And if you search for words with capitals, it sort of pick up headings. So what it will let you do is to track through time, in this case in the 1800s, topics, themes, words, activities that appear in publications. So you can look at things like the prime minister's names, for instance, and you clearly see there's a pattern where prime ministers come into power and they get talked about, and then they go out of power and they don't get talked about as much. In this case, I was just looking at some of these terms to see how much they've appeared. Well, in this case, since the 1800s. So I use those terms which are in red: secure data, federated data, safe haven, honest broker, the things I was asked about. Not surprisingly, you'll see the term of safe haven has been around for years and years and years. It really picks up in 1960s, probably because of data, but maybe not. But it's been used for a long time, for 60 years. The other one was interesting, was secure data, which really became more popular in terms of usage around up into the 1920s. Don't know why. Probably because of the First World War, maybe. Who knows? There's no answer to these things, but it's just an indication that these terms are not new. They've been used for a long time, particularly safe haven, secure data. Honest broker seems to have been going back for a long time as well, but less in terms of its appearance in publications. And the term federated data, very low usage, zero usage, really, right the way up until coming into the 2000s, where it begins to take effect. And that's really how it's felt in terms of some of these things. I'll say why in a minute. If you want to have a play on that, it's quite interesting. So back to definitions. I did some very simple lookups in this case, the online Cambridge Dictionary. Safe haven came out as a place where you're protected from harm or danger. If you apply the data element to that, the safe haven is fairly self-explanatory. It's a place where you could store data safely, keeping it from harm, keeping it from danger. I have to say, that doesn't come without cost, because the safest way of storing data is never to give anybody any access or anything, because that's completely risk-free. And we have been there in the past where data has been saved in big boxes, silos called safe havens, but it was extremely difficult, if not impossible, for organizations or people or researchers to get access to data. That was largely why my data started in the first place, because we were in that position where data was around, but nobody could get access to it to undertake research. So safe havens are fine, but there's a balance to it. You can't just keep data safe. You have to make sure it's used. And when you look at the term honest broker, again, dictionary definition here is interesting because it's applying this principle. Yes, we need to, in data terms, we need to have the data safely kept, but you also need to make sure that appropriate people could get access to it and we could barter and do agreements. So the honest broker thing was quite useful in terms of managing access to data as well as keeping it safe. And that's why we saw people using it. It's used much less these days because things like secure data environments, trusted research environments have become the natural parlance, the natural speak, certainly more common usage across the NHS. But there are some places which do still use it. So in Northern Ireland, they have their own honest broker service. These are some quotations from their page. So Northern Ireland are the only part of the UK I've found at a national level that still actively use the term honest broker service. They haven't yet moved across. But immediately you see a problem there because it says in the first line in quotes, the honest broker service is a trusted research environment. So for them, there's an equivalence there. But the fact that we're using two terms isn't helpful to people in understanding. And we know huge amounts of problems we've got is around communication of how our data is used, how it's stored. So people get confused by multiple terms. So the term honest broker service seems to be used equivalent to trusted research environment. Why not use one would be one question. But these are quotations from Northern Ireland. Interestingly, you'll also notice in the last bullet point, again, a quotation from their site, data can only be accessed via safe haven. So that's another term they bundled into one. Again, not awfully helpful for people, but you're beginning to see these are largely the same things, but using different language. I think we need to move on from these things. The last thing I'll point out here is that the last bullet point is saying about data access. So you can only access this secure research environment, this trusted research environment, this honest broker service via the safe haven, by physically being in their place, in their offices, or via a secure link, which is this secure e-research platform, which you can look about on the web, which is another trusted research environment, a mechanism. So they've implemented they've got 4 of our terms in one area there, describing essentially the same thing. Confused? Well, I'm not surprised because it is confusing with so many terms being bandied around and not really qualified about how they're being used. In fact, that secure e-research platform website also says, yeah, we're finding it confusing as well because there's multiple TREs and multiple data sets. So they're recognizing that the environment we've got at the minute is not ideal to undertake research. And again, it's not great in terms of communicating this to the public. So that's what you get if you look on the websites. Here's my take on this, because I try to simplify it for my own mind to try and bring some of these things to the fore. And I'd be very interested in, when we get to the discussion bit, about whether you think this makes sense or not, whether it needs explaining differently or better, or whether you've indeed have seen better explanations given by somebody else. This is my view. So all this stuff, TREs, SDEs, FTPs, is largely around centralized data storage and centralized data sharing. All the terms relate to big centralized stores of data. I'll caveat that in a minute with one thing. And the more data we've got, the more data gets centralized, the more important it is to use it. Also, you get lots of data sources in different places. And the real benefit comes when you link those together. And that's what these big centralized data stores tend to do. They link data together. When you've got these data storages linked together, these big pots of data in a humongous bucket, what do you do with it if somebody says, can I do some work on it? So some of what I've called here a traditional data access or release service, where a researcher will request access to data to do a specific piece of work. It'll go through an approvals process, and then that data, if it's approved, will get released and given out to, for instance, university, and the university would use that data to do their research. And that's quite a traditional way of working, but it's still being used. I've got some numbers on that later on, actually. Others, which are more recent, relate to this remote access approach, which we've already mentioned. So the idea here is that you don't give data out to, in this case, a university, but you would allow them access into using the secure data environment, this trusted research environment. In this case, those two are largely the same thing. Secure data environment, trusted research environment do exactly the same thing here. They don't give data away. They allow people to come in or to have access to a secure link to use the data in that environment to do all their work. The raw data, our individual records, would never leave the environment. What would leave the environment would be the results of the analysis. Now, that's much safer in that data isn't given away in large swathes to universities and to others, because once it leaves your centralized store building, it's very difficult to keep track of it. It's much safer in that respect, but it brings significant challenges. So if a researcher is working inside a secure data environment, which is run by, for instance, NHS England, well, we've got several thousand researchers out there. So what happens if several thousand researchers suddenly begin to use one single database? Could it cope in terms of storage capacity, processing power? So these databases are having to be built very, very big. The software around them needs to be significantly beefed up as well. Otherwise, multiple researchers would just crash the system, bring it to its knees. And that's one big challenge for SDEs, TREs, secure data environments, and trusted research environments. They're largely the same thing. The only difference here is that the word research appears in the second one. So a trusted research environment is set up specifically to service the needs of researchers through protocols, through ethically approved protocols, through hypothesis-driven research. Secure data environments can do both. They could serve researchers, but they could also serve NHS planners, for instance. So people who want to count the number of activity, they count the number of beds, track various things and do audits. That is not research. That doesn't need the same approvals as a researcher does, but an SDE, a secure data environment, would service that as well. A trusted research environment shouldn't be doing those things because it's just to do with research. And that's largely why we saw the shift of usage from things being called trusted research environments to being called secure data environments, because it gives them more scope to do things with the data. But crucially, the raw data never leaves that environment. Here's my picture then. So here's my picture trying to explain what I said is traditional data release. So on the left, you've got data sources. Let's say each of those is an individual hospital running hospital administration systems, booking systems, inpatients, outpatients, the rest of it. In the middle, you've got a data store. In NHS England, that would be, for instance, the HES data store, Hospital Statistics. In Wales, it's called PEDU, patient episode data for Wales. And in Scotland, they've got another one, which I keep forgetting the name of, but essentially it records hospital activity. I've used that because it's been there for 30, 40, 50 years across the UK in different parts. So individual hospitals send their data and it's replicated in the data store in the middle. So it gets bigger and bigger and bigger. And that's been used for research. So a researcher sits on the outside, the dotted lines delineate the organizations, and the researcher puts their protocol and says, I've got my approvals, could I have some data please to do my research? And the data is extracted from that data source, sent across to the university in light blue. The university stores it on their own IT systems, and the researcher works on that data to do their research or do the analysis. That's the traditional way of working in terms of data being used for research or analysis. If you redraw that slightly for secure data environments and trusted research environments, they do the same thing. TREs aimed at researchers, SDEs aimed at researchers and others, anybody. So they're basically equivalent. In this case, the researcher sits on the outside still, but they're suddenly invited into the camp. So the only way the researcher can access the data is to move inside that physical or virtual data store. They don't get given a release of data. They work on that data using these tools which are available in the data store, the analytical tools. They produce the reports, which are checked by the people who run the data store, or the TRE or SDE. And those reports then leave the domain and can be published. So that's the way that works. It's fundamentally different. The researcher moves inside the SDE, the TRE. And that's why people like this model, because the data isn't given out to multiple organizations. The third model is different. So whilst TRE and SDE are largely the same, federated analytics is very different. So on the left, we've still got these data sources, the hospitals, for instance, in my model. In the middle, you've just got a piece of software. So there's no middle data store there. The data hasn't left the hospitals. On the right-hand side, you've got the researcher. Now, in this case, what happens is the researcher says, I want to run a query against all those hospital databases. And my query is that count the admissions in August. It's a bland thing. The query then goes into the software in the middle. The software fires out a request to these individual data sources, and the data sources run the query on their own databases themselves and send the results back, not the individual data, but the results back, which are collated by the software into the reports. The reports are checked, and then they can leave the environment. So here you've got the researcher doesn't have access to central data, nor does any central data exist. All that exists is some software. So you're basically running a distributed query against all those individual data sources. That's what federation does. It's a very nice model, but there are some significant issues in making it work properly. For instance, all the data sources on the left must be absolutely identical, must be absolutely sticking to the same data standards, must have the same data quality assessments run against them. Any of you that's worked with any researcher will know the term data cleaning, because when researchers traditionally have had their data offload, the extract, the first picture we saw, they spent 6 months cleaning the data because they can see the oddities in it. Weird data come from different hospitals. They have to standardize those and make sense of them. Now, federated analytics relies on that being done at source because the researcher never sees any of the data. Interestingly, when you look at the results of these things, if this was count admissions in August, and these, for instance, were hospitals on the left-hand side, and they were typically of the same size, the same nature, the same types of population, if the researcher in this case saw a weird result where the third hospital got a massive number, whereas the rest of them got relatively normal numbers, very difficult for the researcher to check because they can't look at the source data. This is one of the problems with federated analytics. How do you get back to the raw data to look at where the oddities actually are, whether it's a data issue problem, a data quality problem, or something else, or maybe the queries are not run properly. But that's the way federated analytics work. That's why it's got such a big press at the minute, because it's seen as ultra safe. The data never even leaves the people who generate the data in the first place. Let's say the hospital on the left. It's generated through software. And when you look at the schematics and the videos you can watch about the NHS England's federated data program, this is what you'll see. Their pictures would be nicer than mine, and the videos are nicer than mine. But that's largely it. It's saying the thing in the middle is software, not a database. In this case, Palantir for NHS England have provided the software, but they don't own any database. That's why federated analytics is fundamentally different. Let me summarize that. The traditional data extracts, which we've been running for many, many years, where data is extracted from a big central box and given out to university who've got the right permissions, the right ethical approval. And then the processing for that is done on each of the individual external boxes in individual universities. So if a data set goes out to 30 universities to do similar types of research, you've got 30 university boxes running those bits of software. The secure bit in the middle is where SDEs and TREs sit. It is more secure because the data never leaves a central environment. All the processing is done in the central platform, but it means those central platforms, the SDE, the TRE, needs to be 30 times more powerful than the university machine because you've got 30 universities using it at the same time. So there's capacity issues, computing power issues, and storage requirements that they have to figure out. And then the bottom one is fundamentally different. Federation, the data never leaves its original location, but it's software which fires a query at each individual little local box. The results are collated centrally by the software and sent out as reports. The processing power in this case is shared because each of the local boxes has to run the queries, but the data needs to be really consistent to make that model work. That's how these things are different. And some final thoughts, and then we could pick this thing to pieces. A couple of things on here. There's something called Open Safely, and we're going to be running an education session specifically on Open Safely because this is the best example I can see of a federated process working. So if Open Safety was set up because of the COVID pandemic, it runs its queries on individual instances of GP databases. And those are pretty well standardized, but lots of oddities in there as well. But this has been running successfully. It runs several queries. All their queries are published online. All their queries, the analytical software code is all published on this thing called GitHub. So researchers can look at what other researchers have written in terms of computer programs and can update them, improve them, take them, manipulate them themselves. OpenSafe, they publish on their website all details of who's accessed what data for what purposes and what queries have been run. You can look at it in real time. So it's a really nice model. The other thing it's also done, which I haven't talked about here, is introduce this thing called synthetic data. Now, we've done our own education session on synthetic data, which predicted, interesting enough, that this was going to happen. So one up to us, synthetic data is fake data, but it's given out freely to universities, for instance. They can use it to generate their queries, which can be quite complicated. And when they're happy with the queries, those queries then given to, in this case, OpenSafely to run. That's the model I showed you earlier on, where the query goes into the software. So the synthetic data takes one step further and allows the researchers to really develop complicated queries in a safe environment, rather than having to spend lots of time in the platform doing things which might not work first time around. So OpenSafely is going to be one of our education sessions coming up. That'll be a really interesting one to watch, because a lot of people are seeing this as the future. And my question was, well, is it the entire future? Does this mean the end of all traditional extracts of data that go out to organizations? I don't think it does. And certainly at the minute it's not, because NHS England in the last 12 months issued 500 data sharing agreements, the contracts, if you like, with organizations to which they would send data. That's in the last 12 months. And even in August, there were 1,200 data sets which were sent out within those data sharing agreements to multiple organizations. Again, all those are published on the web. You can go through and query who sees what, which organizations have had what and for where. Quite transparent. Interestingly, 56 of those 500 data sharing agreements were tagged as commercial. And one thing that we haven't talked about within the TRE, the SDE, or the FDP models, or the honest brokers, is how does a non-NHS, non-academic researcher, how does a blatant commercial company get access to data through that infrastructure? Are they allowed into the SDE? Are they allowed into the honest broker service? And some of those things are taxing people at the minute. So as it stands, I still think there will be a need for data extracts to be sent to certain organizations who can't operate within the SDE, the TRE, the honest broker, the FTP service. So all these things will be around for a while, I think. Right, that was my quick rattle through. I'm going to stop sharing now. Feel free to open your microphones or wave your hand or ask a question or make any comment you want. Francesco, you very politely raised your hand. You're a polite fella.
No, I just wanted to make sure I didn't get in front of anyone if they had their hands or spoke. To be quite honest, unless you're part of the public involvement group with, excuse the acronym, HCRK UK, Health Data Research, then for the likes of me and others, everything you talk about isn't that important in terms of what we do. But what is important is that the governance is there. What I do understand is, if you want to get into NHS England secure data environment, there's a just under £400,000 setup fee and an ongoing 300. I've got it in front of me here, £380, because I've seen some of the figures that researchers have to pay to get that, GPRD with the, whether it's standard, acrim or gold, and some of it can be about 80,000, if not more than that. And it's like, presumably the university or whoever, and that's an annual fee, they have to pay into it. But for the likes of me that does PPI and maybe, I don't know, 10% health data, I can't get that excited about it. And there's a lot to learn for little gain for what I get involved with. And that's why they have researchers that, within the clinical trials and all this, they can access all that, but our PPI people actually, actual collaborator, because they're only brought in where it's relevant and not necessarily follow each work package from a particular research. That's my experience. Others may comment differently. So while this is useful, the world keeps changing and it's difficult to keep following, the federated data platform that NHS England given to that American company. It's like, oh, for crying out loud, I'll stick to what I know. Cheers.
Yeah, I suspect many will feel the same. I despair sometimes when I see all the different acronyms that are used and all the different places and organizations that are involved, when it's not explained to people in simple terms what this is all about. So I agree. I'll come back to costs in a minute. And Brenda.
Yeah, going back to language, you mentioned about aggregated. I think you mentioned aggregated data. Is there a term for the opposite of aggregated data? Is it where it's one record per patient? Because quite apart from this data, basically big database situation, quite often come across this in personnel information sheets, and it sometimes I think that researchers are trying to avoid whether they're sharing the aggregated data or the individual data because they don't know how to word it to the public. Does individual data mean what I think it means? And is that a common phrase to represent, one record per person?
Yeah. So there's a few ways that people describe it. One is patient level data. One is record level data. Individual data, certainly. And the other one is identifiable data, obviously, because if it's very detailed, it's likely to be identifiable. So there's a few different terms used at that level.
What was the third one? Individual data, patient level data, or what was the other one?
Record level data is used as well. And disaggregated data, which isn't it?
Oh, wow, yeah. Disaggregated.
Even I don't.
Presumably coming back afterwards. Aggregated. Yeah. So they're all the same, are they?
So aggregated is essentially counts. So like Query I said, count the number of attendances in a month. That'll be an aggregated data. 550.
So disaggregated data is the same as the others. Yeah.
I think it could be. It's an odd one. I try not to use that. I've seen it a few times, but I think it would be the same as the others, the same as individual ones. Yeah.
And the other thing, I don't know whether this was so obvious you didn't mention it, but do all these where the data is being given back to researchers, is this always either anonymized data or pseudo-anonymized data, or is it? I mean, I think sometimes researchers forget to say that.
Yeah, good question. So it's one of three things. It's either identifiable, or it's anonymized, or it's sort of pseudonymized in a way. All three sets of data can be given out to researchers. If you want to have a look at the volume of data that goes out, which is, for instance, identifiable from NHS England, and they also break it down by how many of the extracts have respect to the national data opt-out and how many don't, then there is an online tool you could use, which is the NHS England, what's it called? Data Access Register. If you Google it, you should be able to find that. You can download a spreadsheet, which is big. There's also an online tool you can go through, and you can search by organization type and various other things. I tend to go by the spreadsheet because the online tool is a bit clunky. And I did some searching last night about the number of data sets that have been released in a period of time, and how many of them did respect the opt-out, how many of them didn't need to respect the opt-out, and how many were identifiable. It's quite big numbers. So you get all identifiable and you get anonymized data as well.
Thank you.
I
think
Francesco.
Sorry, I was going to go back to what Francesco was saying about looking at it from, I'm both Francesco and I look at it from a PPI view, really. And also considering, if it's going to go onto this kind of data, our interest probably is looking at whether these terms are going to crop up in participant information sheets so that we know in advance. Yes, the other, as Francesco says, the other bit is interesting, but from our particular perspective as PPI, It's how it affects what the participants are told.
Yeah.
I don't know if
Makes sense.
Francesco agrees with that or whether there are terms that other terms. Thank you.
I'm just thinking on what Sam, hi Sam, by the way, just dropped in the chat. So the data release register I mentioned, thanks to Jackie putting that in the chat, there's a link there you can click onto. That's the traditional data sending out bit that I said about. In terms of the way the SDEs and the TREs work, because you don't take out individual record data, you're not allowed access to that. So it will be pseudonymized, be identified when you begin to use that. Thanks, Sam. Francesco.
Yeah, I don't know the answer to this, but if we take a look at the ambitions of the Department of Health and Social Care and how how NHS England delivers, what we've got at the very top is the NHS outcome framework, the public health outcome framework, and the social care outcome framework. The ambition is that all people should be able to live to the age of 75 for major condition, cardiovascular, respiratory, liver, cancer, and all things. So if people die before that, that's designated by the Department of Health as premature mortality. It very much depends. So you have to look at the ambition. So how do you achieve that? Now, one thing I've looked at as a PPI member, looking at the data that is made available, is that we've got national screening. Okay, so for various cancers, for cervical, for bowel, and for breast. Now, when you look at, unfortunately, the number of people that die from those three conditions as part of the national screening, is too many, but the three combined together is less than those that die from lung cancer. Now, as a PPI member, I'd be looking around saying, where's the equity? You know, okay, if you have a condition where more people are dying, surely the outcome would be around early detection and prevention so that you don't have rehospitalization and people turning up at stage 3 when it'd be more difficult to treat with the various chemotherapy, radiation, everything that goes on. So to me, as a PPI person, it doesn't make sense, but I don't hear anybody from the data side maybe challenging or questioning why is it that the National Screening Programme doesn't look at, they don't do that with ischemic heart disease. They look at the whole gamut of cardiovascular condition, and I can't get it into my head why the number one cause of death of cancer, lung cancer, isn't actually theirs, because the data tells us through mortality figure that NHS England keep through NHS Digital. So, that's why it's kind of like going round in circles. Who's actually listening? Anyway, I just thought I'd mention that because to me it doesn't make sense, and I think somehow PPI people on data must be just there to be part of a committee, because and I'd probably be asked to leave because I have to deal with the reality of how do you improve, NICE may not approve that new Alzheimer's drug because it's not value for money for the NHS. But for people that have to care for loved ones with Alzheimer's, it's a different kettle of fish, and they've always held on to this quality added life value of 30,000 a year, and that was the case back in about 2010. But anyway, I'll stop there. Yeah.
Well, it's interesting because what you're doing is there's two sides to this. First of all, what does the data tell you? And secondly, what do the politicians or the policymakers do with it? So we've known for a long time what the death rates are in cancer, for instance. We've had registries since the 1950s. We've known exactly how many people are getting particular types of cancer, how many people are dying with them, and indeed how many are dying prematurely. Has that informed policy priorities? In some ways it has, but in many ways you could argue it hasn't. Screening program is an odd one because you need to have an effective program to screen. And the ones we've had for a while, breast screening, cervical screening, colorectal screening. We've now got a lung work which is going on to do for rapid lung diagnostic stuff around lung screening. prostate screening's been on the cards for a long time, but there's a question about, is the test effective enough? Because you've got to, if you get a negative, a false positive for somebody who might have a particular type of cancer, they might go through treatment, which they don't need to have because it wasn't cancer in the first place. So there's a whole set of committees which look at the balance of, is screening as an intervention the right thing to do from a cost point of view, but from an ethical point of view as well. So that's where the data really is used. If you look at screening, though, the area of data where screening where data isn't used is the effective monitoring of people who are detected with cancer within a screening round. So if you look at a breast screening, for instance, a 3-year recall process, somebody goes through a breast screen, they're given an all clear, yeah, fine, go away, we'll see you in 3 years. And within that 3 years, they develop a breast cancer. Now, those two data sets are collected very differently. The screening teams collect a screening data set, how many people have been screened and what the result was. Mrs. Bloggs was screened on this day, result negative. The registration systems collect data and be diagnosed with a new cancer. Mrs. Bloggs was diagnosed on this day with a breast cancer. Unless you put those two data sets together, you can't tell people who've been detected with a cancer within that 3-year screening round. And that's the basic effectiveness measure of any screening program. Does it detect people, but does it not miss people? And it's that missing people where those two data sets, putting them together, that's the only way you'll find the answer. So that's one example where data needs to be linked and utilized and shared more frequently. But I know that there's at least one person on the group who worked with the bowel cancer screening, the bowel cancer intelligence area, who were trying to pick up whether bowel cancers were being missed by bowel screening, interval cancers they're called, and getting access to that data took many, many years, and probably, I'm not sure whether it's still happened yet. So there's a basic use of data which could drive policy, which isn't happening. I think that's where our lobbying is. The question you've got is, are the government taking account of what the data is telling them? In many cases, I'm not sure. And that's, again, where we need to have a much stronger voice to say, are you doing the right things that the data is showing you? It certainly ain't the perfect world. And then there's a whole question, as you raised, about cost. Nice, make a judgment based on the cost effectiveness of a particular thing, a drug, an intervention. And the reality is the NHS has only got so much money to spend. And if you want to spend money on this new drug, the money has to come from somewhere. So it might well be you can't do certain things over here. So there are always winners and losers. And when you're that individual, that's not very difficult to see that argument because it's very personal. You know, the fact that I couldn't get a particular drug for my dad was really personal to me, despite the fact that I knew people from a cost-effective population perspective and said, as a population, we're better to spend it in this rather than this. Sorry, mate.
Yeah.
And squaring those things is really, really tough. I don't think it ever will be squared.
Yeah. Thank you.
Paul.
Yeah,
great. Yeah, thank you. There's a couple of points which I, in one sense, this is information and developing, you know, what things mean and so on. One of the problems that I seem to keep coming across is the timeliness of access to data. I was involved with helping somebody. They were doing a PhD on a piece of research, and the literally the hoops they had to jump through, and sometimes it was a case of the application. It would take so long to go through. They then thought, right, I've got it now. And then they said, oh no, we've changed the actual application process now. You've got to fill in this. And they had to go all over it again. And this piece of work certainly went on for about 2.5 years, you know, which was a concern. And the other area, and I really don't know the answer to this, because as much as we're wanting to see all the protections and safeguards, one of the biggest problems I see as well is that in the past, one of the great things that researchers were able to do was come across things. Now you've really got to narrow down and for obvious reasons, narrow down, this is what I'm doing research in. I need this information in order to tease out the hypothesis, is it a negative or whatever, so and so they miss out, because you're very, very limited on what you can get. And I really don't see easy answers here. I mean, I don't know if you've got a view on those 2 points, Chris.
So, yeah, timeliness has been an issue for as long as I can remember. If you're a
Yeah.
researcher, you spend a lot of time building a very complicated proposal. You get the funding from a research funder,
Yep.
and then you apply for the data, and then it takes a long time to go through
Yeah.
that paper process of filling the forms in, jumping through the hoops, as you say.
Yeah.
It could take a long time,
Yeah.
inordinate amount of time. The theory is that, well, the one reason for that is once the data has been given to you, it's been given away, it's very difficult to keep track of. The theory of the secure data environment is that it becomes safer because whoever runs a secure data environment, and just England, they can watch what you as a researcher are doing. They can make sure you're doing the right things and not doing things you shouldn't be doing. And they can immediately switch you off. So
Yeah.
it's a much safer way of working. Whether that speeds up the application process or not, I don't know. I haven't seen any evidence of that yet.
No.
But we may hear that that's different with people like OpenSafely. I don't know yet.
But
But you
yeah.
still need to go through that application process. But I'm not convinced
Yeah.
it has yet sped things up. That's
Yeah.
your first point. The other one about it takes a long time for a researcher to build that hypothesis. They only get the data they need to answer that one specific question. That's sort of the way research works.
Mm.
If you contrast that with artificial intelligence needs vast amounts of data to find stuff in. It looks for patterns.
Mm.
Researchers used to call it fishing trips, go in and dangle your rod in and see what you find,
Yes.
which was very much frowned upon from the research community
Yeah.
for all sorts of good reasons.
Yeah.
But artificial intelligence essentially relies on that. Give me
Yeah.
access to all the data. I'm going to look for stuff. I'm going to see what flashy things I can find. And it's in complete contrast to the way research has been run for the past 40, 50, 100 years in the country.
Yes.
And again, there's a big dilemma. There's an ethical dilemma there. Technically possible, ethically difficult. Oh, Jackie put her hand up. She's good at this stuff. Go on, Jackie.
I think it's perfectly ethical to do blue sky research and look for links. We should do. As long as it's registered as such, blue sky research. I know a person who's a metallurgist. He did some blue sky research and ended up improving the efficiency of Harrier jump jets. It's necessary to find new things. We can't say we know everything about anything. So I'm all for it.
Right. Good.
And interesting. If I replayed that in two ways, one is there's huge amounts of data we could learn how to detect lung cancers much earlier because that might be in the data, or that's a good thing. Or you could also play it and say, you're going to give all the data on everybody to this organization. What? And that's the dilemma we're in in terms of public perception.
Yeah.
Giving the data all the way to this big AI engine, or saying if we did this, we could prevent lung cancer. We could detect it early. We could stop people dying. We could improve the figures on premature mortality that Francesco's flagged up. So there's some really interesting dilemmas being played out in the public here. Go on, Jackie.
Or if we had data regarding patient nutrition, we could find out some very interesting things about how their illness progresses or even starts or not. For example, there's a whole load of brain research lately that is finding, and there are papers that say people over 70 should really take these supplements to prevent dementia, or at the very least, put it off. And there are some products out there that apparently really work.
Yes,
For those who think their
research
memory might be going.
Brenda.
Yes, it needs proper research.
It seems to me that yes, you want people to have other people's data, but not your own. Once you get an open thing, you say, oh, hang on, my data might be on that. I might have a different attitude to that, which shouldn't be the case. I mean, it should be. To me, this is why it's necessary to adequately anonymize it. Because if it truly anonymized, why not give everything, all the data to everybody? It's only when to me, when you start linking different sources and possibly even give data that could be linked by the researcher to other sources. Sorry, I'll just turn this off. Then it gets dangerous, because you've got no idea of what's going, what's going to be found, and what data is going to be indirectly identified. I don't know if you agree with that, or
what government is going to do with it.
Well, we'll come back to that in a minute. So one of the problems with giving data out to a university is once it's gone, it's gone. They could, in theory, link it to other data that they have, which they're not supposed to do. So you're quite right, there's a risk of that. The benefit of having a secure data environment run by, for instance, NHS England or Scotland or SAIL in Wales, is that organisation has to act responsibly, and they should be audited and governed. But the linkage could happen there. The linked data could therefore be used beyond that point without the identifiers in it. That's the benefit, really. So the SDE and those sort of processes would be able to link data within the environment, but the researcher wouldn't see the identifiers. They would just see the data that's been linked, not knowing who that person is. So they wouldn't know it's you, for instance.
But to me, one of the problems, though, is it's all right taking out the name, address, the postcode, even the NHS number. Well, that's beginning, I think, being dubious, a lot around that. But if you, for instance, identify people, I don't know, over 7 foot tall, or people who have had an operation in a particular hospital, but a particular, it then becomes somebody looks at, if they get this individual data, I know somebody who had that operation. Look, the first part, their postcode is near me. I'm not, it's probably people I don't know, maybe some of the public are more bothered about what the man next door finds out about them than they are about, even what DWP found out about them, or possibly, American commercial companies find out about them.
So if that man next door was a senior analytical statistician working inside one of the teams in NHS England that has access to that data, which is one of the few, then that person might be irresponsible and try and look those things up. They'd immediately be fired. They'd probably be prosecuted. They never work again. So there will always be people who might do bad things. We've seen stories of nursing hospitals who pick somebody's notes up of a neighbour. It's against the law, and there need to be safeguards to do that. But I don't think you can ever really stop that happening. You can try and prevent it as much as you can by taking identifiers off, but the more detailed information becomes about a care record, the easier it is if you know something about that person to figure out, that's so-and-so, if you were able to see it. The thing is, very few people could see that. Researchers might be able to see parts of it, but not all of it, as Paul says. And even they have to act within legal frameworks, but they could be prosecuted. They would lose their jobs. The university would be fined, maybe not even get any more contracts for research funding, and their world will fall to pieces. So there are safeguards, but you're right. There are always going to be risks about people who act badly. And as well as universities, the other side is, as Jackie said, the government. There's a large distrust in the way government operates at the minute. And governments do have access to large amounts of data which they want to link to drive their policy agendas, to understand how the population works. That needs large amounts of data. So that government's objective is where there's a fair amount of distrust, probably not enough transparency about what data government does or doesn't link together and what it does and doesn't do with it. It's very difficult to find out.
Yes, I agree with that. I think it might be interesting to find out when people distrust data, that somebody won't participate in research because they don't want anybody to see their data. Exactly what are they worried about? Are they worried about the DWP finding out? Are they worried about the government finding out how much they've got in the bank? Are they worried about the person who works in the research centre, or even the GP staff, finding out about them? That wouldn't be otherwise.
All those could be possible, and it'd be very personal to people, because we're all different. We all have different views. We know what we know. We don't know what we don't know, and there's inevitably a worry about who can see what of my data, because it's incredibly difficult to find out. If I were to try and find out now who across the NHS and academia and commercial organisations has seen
Yeah.
what parts of my data in what level,
Yeah.
I think it would be impossible for me to do that.
Yeah.
So
Which
the
is
point
even more
about putting,
worrying, because this is street gossip. You know, you might never find out what somebody, well, you probably wouldn't find out what somebody finds out about you.
yeah, and if I did find out what was happening with America, maybe I would be reassured and say, oh, yeah, it's okay, because this person can see this, but it tells me nothing about me. It just says I've had X condition. So I may actually be reassured by that. But until we put us at the heart of it, until we give us as individuals access to our own records and we can see what's in
Yes.
there and we can
Yeah.
see what other people have seen of what's in there and we
Yeah,
can track
exactly.
that,
Yeah.
you'll
Yeah.
never really sort public trust out. So that's
Yeah.
a crucial point for me.
Yeah.
Sorry,
Correct.
Francesca, you were very patient there. I
No,
talked
no,
over you.
no, that's okay. It's always good to listen and learn. A few points of facts, okay? For you, Brenda, there is a national opt-out website that you can go to fully or partially not allow any of your data for research to be used, either for research or for service development. I do it every year and just check. The government made it possible or for your GP practice to check your electronic health record through a website that's linked to your GP app called Patches. My bloody GP practice, they're not up to speed, so I cannot access my electronic health records to check for any inaccuracies, omissions or otherwise. For you, Paul, NIHR, you were talking about applications and that. Oh boy, are they setting the bars, more bars and a bit higher. As of January, applications have to include equality, diversity and inclusion. They've had the first webinar and all the funding committee and reviewers will get their training next month. But I feel sympathetic for areas like Northumberland, Cumbria, Cornwall, where in terms of nationality, race and ethnicity, there's little or none compared to Hackney, Haringey, Leicester, Bristol, Manchester. So, but you can obviously, you do use the data to actually show that. So that's where data comes into it. And obviously, one thing that they get wrong, and you can correct me on this one, Chris, the Office of National Statistic and the UK Statistics Authority, they're absolutely rubbish when they do their categories of different, when they do their census and that. The definition, and this is supported by the Law Society, is that everyone else other than white British is a minoritized group. So that means Italians, Portuguese, French, Slovenians, they have to be given the same degree of consideration if there is a factor. It's not all based on race disparity on people of color. So, that has to be factored in. The point I'm trying to make is that a lot of researchers, they make the mistake of thinking by having people from a minoritized background, they're kind of like fulfilling the diversity agenda. But this week is the Invisible Disability Awareness Week. 90% of disabilities are invisible. You cannot see, people that are autistic or got ADHD. You may recognize it through their behavior, but you don't see it in the same way as somebody in a wheelchair with cerebral palsy or motor neurone disease. And the other thing that NIHR want is at the end of a research project, they're asking for synopsis rather than a final write-up with dissemination. And that is why, in some ways, us PPI people, they won't employ us because if an employment contract comes into being, then you're entitled to sick pay, disciplinary grievance, maternity. And that's why we'll always be playing bit parts on whatever they're paying. Temporary contract, honorary contract, they're few and far between. But I take your point because I work with postdoctoral fellowship applicants and that, and they need to get it right if they want to get past the hurdle and get invited to an interview up in Leeds for their 3 years full-time or 5 years part-time PhD. Yeah, I thought I'd just throw, and the other thing I was going to say, Chris, it gets more confusing because University of Bristol and the University of Edinburgh are putting together this longitudinal linkage collaboration where all longitudinal research information will all come together. But having spoken to them, at least you can access their information currently for free, whereas all the others, you have to put your hand in your pocket in order to get access or membership, call it what you will. Yeah.
So there's all right. I'm just conscious of time. There's a few things. We might actually do a session on how much it costs to access data because some of the costs are extortionate. Some are free.
Absolutely.
I'm not going to answer that. You mentioned the national data opt-out, which is England only. You're quite right. If you look on the link that Jackie's posted, it tells you all the data releases. I just had a quick look. There's 1,200 I mentioned that were in August this year. 1,200 data releases. 400 of those didn't apply the national data opt-out and didn't include identifiable and sensitive information. So explaining the national data opt-out to people isn't as simple as saying you can opt out or not, because even when you opted out, some people will look at this and say, hang on, I've opted out, but 400, a third of the data releases that have gone out have included my record, even if it's sensitive and identifiable. How's that right? So there's a real communications issue around that. All that's on the web if you want to have a look at it. We don't have a session on the national data opt-out, what it means and what to look at it plan, but people could decide whether they want that or not. Yeah, we got the other bit. It's probably too much. Actually, I'm worried about time. The one thing we're gonna have to wind up in a second. I was just gonna say one thing is the questionnaire that came out in the newsletter this week from Elizabeth, which we've got a national patient awareness day today. We've got a national patient data conference next June, and we're looking for ideas about what you want in that conference. It's a conference for you, by you. It's not going to be designed by me or any professionals. We're really interested in what you want to have on there as topics. Kerry's on one of the organising committee for that. So if you get a chance, have a think about what you want to hear or discuss or ask people about at that conference. We'll have some very high profile people there if you want. If you want to have a question time session and grill them with whatever your questions, I don't know. If you want a topic on X, we can organise that. So I'd encourage you to have a look and fill in that questionnaire, which shouldn't take long, but we're trying to get as many views from people about what they want to see in that conference as possible. Right, 11 o'clock. Oh, go on,
Chris,
Brenda, go for it.
Yeah, a practical detail. I was just trying to access the chat so that before you close down, and I can't seem to get into it. Is there any reason?
No, it should be there. I can see it.
Oh, it's all right. Got it. See if I can copy it.
Can you see it now?
Yeah, it's okay. I've got it. Yeah, thanks. Yeah, thank you. It's very useful to do that at the end of a session.
Yeah, actually, it does send me a copy of the chats to my inbox. So if anybody needs it afterwards, we can put that on. We tend not to send it anywhere else because unless you've been here, it would be unfair to share our chat with other people, which is why we generally don't put the chat bits on. Although Jackie's tried to do some editing and do some useful stuff on the back of that as well. But we generally don't put the chat on there. But if you want a copy of it, I don't think there'll be any problem.
Thank you.
Just email
It's
me.
just the usual thing to remember to copy at the end of the session.
Well, if it's helpful, I could try and routinely send the chat out afterwards to people. Chat. I'll try it this time. See if I can do it.
I don't know what other people think, but yeah, that might be a question to ask. People.
I'll send it round, and if it's of no use, then just ignore it. But I'll just see what I can do that, and it might be something for next time.
Okay. You do know, don't you, that you can copy all that chat and bring it over to your own document if you paste it special without the formatting, which would be HTML partly.
Well, I've just done that, and that's what I usually do. Certainly for this one. Some of them won't let me, but I need to do that before the end of the session. It's just a case of remembering. I'm trying to listen. Thank you.
Okay, well, if ever you forget, just email me and I can it goes into my inbox somewhere.
Can I just make a comment to Francesco? Yes, I did know about the opt-out, but presumably for use my data, if part of our remit, if you like, is to try and encourage the public to let researchers use their data. And so indirectly maybe try to persuade them not to opt out. I don't know whether.
Yeah. Well, I'll throw one thing because it's a good point. We know that there are some of our members, can't give the numbers, have opted out, not because they don't want research to happen, but because they want it to be done in the right way. And what they want is certain things to be put in place that would persuade them to opt back in. We did wonder about having a session at the conference to try and bring some people who've chosen to opt out to say, what would help them, what would persuade them to opt back in? Because that's not really been looked at all. But because it's a very personal choice, it's quite difficult. I don't know who they are unless they came forward, but it's quite difficult for somebody to go on stage and say, I've chosen to opt it out in an audience where they know most people want to opt in. But I think it'd be really interesting to find out from people who have opted out, what would help you? What would you want to see that would say, I'm happy with that, I'm going to opt back in?
Yeah.
And I don't think that conversation is being had at all at the moment. So
No,
again,
we've tried to
something think
start
about.
it.
Yeah,
But-
at the conference. At the conference, it might be something to mention just before a tea break or something, but people could discuss it. You know, and it might be quite an icebreaker.
Mystery session.
We could even have a post-it board so people could put their suggestions on the post-it board anonymously, so they don't need to identify themselves and say this must happen unless without that I won't opt back in. Yeah. Anyway, just a thought.
Yeah.
Right, folks, we're gonna have to go. Thank you for another
Yeah.
interesting
Thank you.
discussion. You never know where these things are going to go. It's always good to speak with interesting people with really interesting views as well. Thanks ever so much. Have a great weekend.
Okay.
I shall be off to
Thank you.
Lanzarote tomorrow, and I'll see you in a week.
Oh,
Good time.
lovely. Great
I'm
stuff.
sorry. What can I do?
Enjoy yourself,
Don't
definitely.
you worry. I will. Right. Take care,
Yeah,
everybody.
enjoy.
Thank you.
Yeah, thank you. Bye.
Bye.